Good evening, everybody. Respected President Dr. Abhinav Bhosle, sir, other office bearers of SAMS, today's invited esteemed faculties, respected Dr. Siddha Chakravar, sir, which is popularly known as the CPR Man of India and the chairman of IRCF, and Dr. Gakesh Garg, the professor in palliative care in AIIMS Delhi and ex-editor of IJA National, and Dr. Rajesh Jivan, who is the Director of Training and Education IRCF, and now presently he is a National GC, IIC and Dr. Syed Moeed Ahmad, Vice Chancellor, AL Karim University, Katikar, BR, and Dr. Vivek Gupta, a consultant anesthesiologist, a cardiac anesthesia and intensive care from Ludhiana. All National GCs, SAMS Advisory, all the past office bearer of SAMS, all GCs of SAMS, President, Secretary, and dear ISF. I welcome you all in today's SAMS curriculum, that is webinar on IRCF, Bcls and Acls. We will start the program with a prayer. Now I invite our
हॅलो हॅलो शीतल, तुझा आवाज येत नाहीये. हॅलो.
हाँ सर, मी करते फोन शीतल.
Okay, okay, no,
Hello, sir.
no problem. I will start my introduction of the topic. No problem. Can you hear me, no?
Yes sir.
Yes. Good evening, everyone. I welcome Dr. Chakrarao sir, chairman, and his team, IRCF. First, I extend my warmest greeting to those celebrating Eid Milad un Nabi. It is a privilege to gather on such a blessed day to discuss a vital life-saving skill. Every citizen is lifesaver. It was our motto. Now, every anesthesiologist. Hello. Hello.
Sir,
Every anesthesiologist, a certified trainer, will be our next motto. We at SAMS have been demonstrating and creating public awareness on CPR for a long time. Every anesthesiologist is skilled and trained in CPR, but only a few are certified trainers. The Indian Resuscitation Council Federation has formulated evidence-based resuscitation guidelines adapted to Indian healthcare needs. It aims to train a reverse network of certified instructors and establish strong public awareness program. To know in detail about how to become a certified trainer, how to issue a COLS certificate to layperson, a latest guideline, recent update, all your question can be answered here from the authority. So please continue and join this informative webinar. Thank you. Thank you very much. Over
Thank
to
you
Sheetal.
very much, sir.
Next.
1 minute. Taking this opportunity, I would like to request all the delegates kindly register for our annual conference, that is SAMSCON 2026, that is which is hosted by Organization of Anesthesiology Satara branch. Now, today's MMC observer, he is from Nagpur, Dr. Sanjay Kriplani. He has done his MBBS and MD anesthesiology and FICM, and he is a director of critical care Max Healthcare Hospital at Nagpur, and he is a known critical care specialist, excellent clinician and academician. His specialty interest is poisoning, trauma, tropical fevers, and obstetric critical care. Now, I invite Dr. Vikas Karne sir to kindly introduce our first speaker, Dr. Chakrarao.
Thank you, Sheetal Madam, and good evening to all. And it is an honor and privilege to welcome Dr. Siddha Chakrarao sir here. He doesn't need any introduction, but still I'll try my best to introduce him to all. Sir is chairman of Indian Resuscitation Council. He is also member of Constitutional Committee of WFSA. He is a former additional director of Medical and Health Services of Andhra Pradesh. He was President of ISC National 2014 and Secretary ISC National 2008 to 2011. He is a founder of Family Benevolent Fund and Managing Director of Care Emergency Hospital, Kakinada. Sir is receiver of Dr. A.P. Singhal Lifetime Achievement Award by ISC National in 2021. He has also received IMA National Dr. A.K.N. Sinha Award in 2021. Is creating awareness on cardiopulmonary resuscitation in India, starting Indian Resuscitation Council, creating highest number of CPR training in India for World Restart Heart Day on 16th October 2018 and 19. He is a guest member of ILCOR. He has released Indian Postal Stamp and Envelope on WRAH Day on 16th October 2020. The best all-round performance in NRHM programs in 2004 and 5. He has received gold medal from Governor of Andhra Pradesh for enrolling more members for Red Cross. Sir has six publications in Indian Journal of Anesthesia. He has attended Roundtable Summit at China by CSA in 2014, attended and presented lectures in Malaysian Congress, and also attended World Congress of Anesthesia in 2012 and 2016. Good evening, sir, and welcome to today's webinar. Over to you, Sheetal Madam.
Thank you, sir. Now I request our President-elect, Dr. Rajesh Tagadpalli, sir, to kindly introduce our next speaker, Dr. Rakesh Garg, sir.
Thank you, Sheetal ma'am. Good evening, all. It is my privilege to introduce such a great academician, Dr. Rakesh Garg, sir, and I am really feeling proud. He is a perfect academician and our President-elect of ISA National for the next year, November 26 to November 27. He is a professor of onco-anesthesiology, critical care, and pain and palliative care, AIMS, New Delhi. He is a past honorary secretary of ISA Delhi and council member of ISSC Delhi, governing council and executive member of RSSCP from 2018 to till now. He is a national executive committee member of All India Difficult Airway Association and also vice president of from 2019 to 2021. He is an executive member of Society of Onco-Anesthesiology and Perioperative Care. He has received so many awards. Main awards are the President Appreciation Award by ISA National in 2019, ISA Bhopal Award for Academic Excellence in 2019, and Bhojraj Award in 2018. He has total 450 publications till now. He is the author of 49 chapters in the books and editor of 2 books. He has written biography. His biography published in 2016, and he has received the Singapore Medical Journal Review Recognition Award in 2015 and 2017. Really, the words are not enough to introduce him, and thank you.
Thank you, sir. Now it's my honor and privilege to introduce the National DC of ISA, Dr. Rashesh Diwan, sir. He has done his MD Anesthesiology and DA. He is a Director of Training and Education, IRCF, and he is a ISA National Governing Council member at present. He is a President-elect Association of Indian Ophthalmic Anesthesia Society. He is a past President of Gujarat State Branch ISA. He was Executive Board Director, Academy of Traumatology. Then he is a Senior Faculty, National Trauma Management Course. He is a reviewer, that is I International Peer Review Journal since 2005. He is a faculty of World Congress of Ophthalmic Anesthesia. He is a recipient of West Zone ISA, Dr. W.P. Thate Oration Award, a recipient of Gujarat State ISA, Dr. S.K. Shah Oration Award. He is a recipient of Dr. Geeta Patel Lifetime Achievement Award. He is a past president Anesthesiologist Association of Ahmedabad and chairman of All India Difficult Airway Association. He is organizing chairman for both ISACon Gujarat 2070 and organizing chairman ISACon in 2021, and past ex-honorary anesthesiologist to achieve the governor of Gujarat for, since last 10 years. So we welcome you, sir, in this SAMS curriculum. Now I request Dr. Shilpa Tivaskar madam to kindly introduce our speaker, Dr. Syed Mohit sir.
Thank you, Dr. Sheetal. It gives me immense pleasure and pride to introduce none other than Dr. Syed Mohit sir. And sir is Vice Chancellor at AI Karim University, Katihar, Bihar. Sir is a former chairman and in charge of ICU AMU. Sir's achievements: sir is Editor-in-Chief, Journal of Resuscitation, past EIC member of Indian Journal of Anesthesia Central Supplement. Sir is a lead author of Indian CPR Guidelines. He has co-authored the Indian Guidelines for Difficult Airway Management. Sir is President of All India Difficult Airway Association from 2026 to 2028. Sir is past Chairman of ICCM UP and UK chapter and past President of ISA UP. To his credit, sir is felicitated by Honorable Vice President of India for CPR Guidelines. Sir has received Dr. Bhojaraj Award for Best Review Article in 2016 and Indo-US Distinguished Academician and Researcher Award of the year 2008. Sir has been with WTG Morton. Sir has received WTG Morton Distinguished Professor Award, ISA Bhopal Academic Excellence Award, ISA President Appreciation Award in 2015 and 2017, awarded Common Health Fellowship in 2009, awarded Fellowship by American College of Chest Physician, awarded Fellowship by Indian Society of Critical Care Medicine, awarded Fellowship by International Medical Science of Academy, awarded Fellowship by Indian College of Anesthesiologists. We are very proud to welcome you, sir. Sir has a lot of publications to his credit, around 130 publications, 2 book chapters. Thank you, sir. We welcome you. Over to you, Dr. Sheetal.
Thank you, Dr. Shilpa. Now I request our treasurer, Dr. Sachin Chandukar, to introduce Dr. Vivek Gupta.
Thank you, madam. It's my pleasure to introduce Dr. Vivek Gupta, sir. Sir is the HOD and cardiac anesthesia and intensive care physician, and sir is at Dayanand Medical College and Hospital, Hero DMC Heart Institute, Ludhiana. Sir is a president-elect of Southwest Asia, African West Asia and Africa chapter of Extracurricular Life Support Organization. With this past president of ICMO Society of India. Sir is also instructor and training site coordinator for ISA, BCLS and CCLS courses, lead instructor for AHA, BLS and ACLS course instructor, FCCS and basic courses. Sir was awarded fellowship of ICCM and FICTA, fellowship of cardiovascular and thoracic anesthesiology. Sir is a teacher in ICMO training courses for ICMO Society of India and teacher in IDCCM, Indian Society of Critical Care Medicine. Sir was awarded IME National Award for training in 2019 and also got ISA Best Trainer Award in 2021. Sir got enormous number of publications. Sir is a section editor for API textbook 2016 Critical Care section. Sir was also editor Anesthesia Update book 2016 and editor on ICCM ICMO CRRT book 2nd edition and 3rd edition. More than 30 national and international publication with more than 50 chapters on critical and renal replacement therapy and ICMO. Over to Sheetal ma'am. Thank you, sir.
Thank you, Dr. Sachin. So I welcome you all in this SAMS curriculum. Now I request Dr. Chakrarao sir to kindly go for his talk.
Good evening, everybody. I am Dr. Chakrarao, the chairman of the Indian Association Council. I just wanted to give a small introduction about what is CPR and how it is going on in India. Just tell me after 15 to 20 minutes so that I can stop, otherwise it will be a lot of issue. So, you know this man, Abdul Kalam, our past president of India, he has suddenly succumbed to cardiac arrest on July 27th in 2015 at, when he is giving a lecture in IIM Shillong. There is a lot of people, but he was not properly resuscitated and he succumbed to cardiac arrest. In 2016, there is a publication from Times of India saying that 98% of the Indians are not trained in cardiopulmonary resuscitation. Yes, it is true. Because even when I was a medical student and we are medical students, it was not even taught in our medical colleges. Only in anesthesia, they say that you compress the chest and all, and we don't know what for we are compressing the chest and all those things. And it is never written in any of the curriculum of the anesthesia books. Of late, of course, about 7-8 years back, Miller has mentioned about the CPR guidelines and everything. Prior to that, there is no mention about CPR, and definitely nobody knows about CPR in India. So, with this, there is a lot of thinking in ISA. So, as being the past president, they have asked me to form Indian guidelines, because the American guidelines that are existing in some of the corporate hospitals are very expensive and they are available in only few corners, and they are not actually serving the people, victims of the outside the hospital cardiac arrest. They are only treating only the cardiac arrest within the hospital. So I requested all these people, and these people have assembled on their own in Hyderabad. Of course, I'm not from Hyderabad. I'm about 700 kilometers from Hyderabad. I asked them to come because it is the center of the India. Many people have come from different places. You can see Dr. Rakesh Garg, Syed Moeed, Rashid Dewan, and Mukul Kapoor, Dr. Radhakrishnan, and so many people are there. They have come with interest to create something. Here there is our SRMC, this one is also there. So these people have come. They have decided, they are on discussion, we should have Indian guidelines. So what is Indian guidelines? How we have to make the Indian guidelines? Actually, at the end of this discussion, they have entrusted the job to about 5 people, like Rakesh Garg, Moeed, Rashid Dewan, Mukul Kapoor, and another person, I think Diveti or somebody. So all these people were asked, Baljit Singh, because all these people are nearer to each other and they are in Delhi, so they can discuss and contribute and write the guidelines. We are given about 3 months' time, and they have done a wonderful job, and they have brought the Indian guidelines. Why Indian guidelines? Everybody says, yes, every human being is same. Why there should be Indian guidelines? Yes, we need Indian guidelines because our situation is different. We do not have, first of all, mannequins. We do not have an AED. We do not have real good ambulances. and we do not have the knowledge of CPR. We have multilinguistic problems, we have religions, we have superstitions, and so many other things. So we should have our own guidelines, and those guidelines were brought up by these people, and they were presented in Kakinada on 17th of October 2017. So this is the thing, and here Mohit is being felicitated on that day by one of the ministers of Andhra Pradesh, and this is the, so all these guidelines are published in the IJA, and it is there. And again, it was inaugurated. Actually, the inauguration should be in a grand man, and ISACON 2017 Kolkata, they have inaugurated. Meanwhile, the people have known, not in India, the internationally they have known that India is bringing the guidelines. So So here, I wanted to tell one word, because of these things, it is happening. The ILCAR has got a sense, and they indirectly invited us to come and meet them as a guest member to South Africa. Myself, Rakesh Garg, and another person also went there. We have participated in that. That is the team in the on the bridge. We have demonstrated. We went to Johannesburg. We have demonstrated CPR in front of the Gandhiji statue, and so many things have happened. And finally, again, we could catch the Vice President of India, Venkaiah Naidu, and he has released the manual. First manual he has released. Again, the second manual is also released on another day. All the ISA members have come, and it has happened. And then the person on the my left side is my right side is Dr. Vinay Nadkarni. He caught me up and he said, I think you are doing and you have to do and you have to become a ILCAR member. Actually, at that time, I don't know what is ILCAR, but he told me, then the organization, if you do it, definitely it will take about 5 to 6 years to become a member. And then I asked why 5 to 6 years, we are already doing, we are qualified. Then he said, you are all the anesthetists. It is not the only anesthetist. You have to have emergency medicine physicians, cardiologists, and so many other people. At that time, there is not much of a department of emergency medicine in India. Only few medical colleges have got emergency medicine departments. In 2022, the NMC has given a declaration that an emergency medicine department is a mandatory for to continue a medical college, and it is going on even now. Many of the medical colleges do not have emergency medicine department. So it is going on like that. Now again, we met in All India Institute in presence of our cardiologist there. And meanwhile, we are celebrating World Restart a Heart Day on October 16th. And in the first instance itself, we have trained about 2 lakh people and we have come first. So this is the publication again. They only are doing their publication. These are all the regular publications they are doing. And we have also went out and trained in the heritage places and everything we did. And we are trying the village people. We are trying the kids. Kids saves the life is one of the slogan. So we are trying the, and we have asked for the low cost mannequins. This fellow has come from Norway. This is our guest house in Kakinada. He has tried to do a low cost mannequin, but finally it has not come. And this is and the thing actually in South Africa, where we have contributed most cases. This is during the COVID, and during the COVID we had a beautiful on stage online meeting. We have released a first day cover, and this one again every year it comes. We met the Bcls. At that time, he was the chairman of the NABH. He has accepted, and there was a world record. Again, the WFS has conducted, and we have approached the actually Dr. Garg has done a lot of things, and he has approached the CBSE school, and the guidelines of the were introduced in the 9th class curriculum. So these are all the guidelines in the 9th class curriculum you can find. And again, NCERT has given a letter that the from 9th class onwards, the training has to be given in Bcls at least, but it is not being followed because it is not mandatory. It is not if they say only an examination and a pass mark, then it will be happen. So these are all the associations whom I have approached. Emergency medicine. There is an emergency medicine educators. So EMRI and all these people have joined us, and but of course including the trained nurses association, gynecologists, critical care. Critical care is taking a little interest, and they are promoting the CPR in schools. And again, everybody is telling how we are doing. We should have some research and publications. So we started the Journal of Resuscitation with Syed Moeed as the editor-in-chief. This is the second journal in the world, the Journal of Resuscitation from India. And we're all moving, but there is no membership for us in ILCAR. Dr. Vinay Nadkarni is encouraging us, and finally, on 1st June 2023, we were recognized, and India is introduced into ILCAR. This is a very big, actually, achievement, more than anything, more than an Oscar, more than any other award, because many people before us, they have tried and they have failed. This is the letter, and this is the photograph. And she is the nursing registrar from Andhra Pradesh. All these people are there, and we have. This is one of our friend, Lokesh Edara. He has helped us a lot, both financially and otherwise also. When we are going to these places, touring these places, he only financed everything. And this is again in Australia. And now I will show you what is our position in ILCAR. ILCAR is the body, a licensing body of the countries where the resuscitation is going on. Actually, the resuscitation is started by AHA, and later it was adopted by the ERC and other countries. So now there is a council for the Asian countries also. They have asked us to join there. I said it is not possible because we cannot compete with even Singapore, Japan, and even Korea and all those things. We have our own problems, and we have 147 million people to teach in our own way. So we were there, and this is our. So this is the organizational chart. Indian Resuscitation Council is there. We are at par with the American Heart Association. We have voting right, 4 voting rights, and they have also taken about 8 people from India to write the guideline. The present guidelines, 2025 guidelines, which were released in Rotterdam, were written by Baljit Singh, Arun Bansal, Rakesh Garg, Alok Samantre is sitting there, Lokesh Tiwari, and Vera Ramaswamy, and another person is also there. Nimbalkar is also there. So these are the people who have, actually recognize, and you all think that American guidelines are different. It is not the American guideline, it is the guidelines of the ILCA, and they are practiced by America, just like IRCF is practicing. So we have achieved the prime important thing. I wanted to tell you again and again, we are nothing lesser than anybody. We are at par with AHA, and our main motto is to save more lives and to decrease the cost of the training. When they are charging about 15,000 rupees, we are just charging about 1,500, and out of that, the IRCF get only now, as per the revised prices, it is only 650 we get. We even with that, the IRCF is surviving, and we made the course is free, but I just wanted to apprise you and appeal to you that don't give course training for the doctors and the nurses, because the course training is different. That is outside the cardiac arrest, outside the hospital cardiac arrest, and doctors and paramedics also need the to treat the cardiac arrest within the hospital. And not only that, these people can afford, and that is a complementary thing. So don't do COLS training and say that I did this and that, but it is a mandatory to do course only to the school children and lay people. This is Dr. Srinivas, now the member of the Niti Aayog. At the time, he is the chairman of All India Institute. He has recognized us, he has accepted, and he has introduced the trainings in All India Institute. This is actually Health Sector Skills Council. It is an NGO, but they have got a lot of influence. So they also invited us, and they had also taken it. This is one of the photos when we went to, I think, Australia. No, this is Taiwan. And so we are moving like this. There is an impact. Well, many people have said when they told that 98% of the Indians do not know CPR, have you assessed again and find out that there is any change? I said it is difficult to make an assessment and estimate, because they are national paper. They could do it. If I write, even the people who are listening to this will not answer and will not fill the forms, and there will not be, because I tried it before with to know how many mannequins are there with us, and I could not achieve. But in future, definitely, with all your cooperation, we'll do it. These are all the people, and these are all the committee members in ELCAR. These are all representing India in ELCAR. These are the two nurses. She is an emergency medicine physician, and these are all the. Of course, some of the slides are old. We have training centers. Because of the nomenclature, we have changed, because we do not want a conflict with the AHA. So we have in Andhra Pradesh itself is 46 CRTCs. Now it is actually this was an old one. We have 170 CRTCs in India spread across, and we have to, with all your cooperation, we have to make another 170 in Maharashtra itself. We have instructors, we have CCLS. Now this CCLS is, we are making it as ACLS because of the issue in the NMC. We approached the NMC, and actually with our effort only, the NMC made a compulsory the compulsory training of Bcls to all the house surgeons, and later they have given a letter. They made it compulsory, and they have given a letter. Bcls and ACLS should be done before any graduate or postgraduate comes out of the institution. So this is all what we have achieved, and this is the data collection form. I will send you, and World Restart Hard Day will be coming soon in 2016 in October. Even before that, you please get it up. I'm sending you the form, the Google form, where you can write. And I request you to write the correct name of the person who got training, including what he is registered in the school or something like that, and if there is a mobile number, you mix it in. And this is 2024 LCAR meeting, and this is all same. And here there is a demand mandatory BLS technique and everything. Sudden cardiac arrest, they are telling. We wanted to identify the first responders and make an app so that we should be able to locate them just like we locate a Uber taxi when there is a need. So there is a problem in India regarding the transport of the ambulances. So we have also requested the government of India to utilize the drones to easily transport these things. And there are a lot of things actually we have done regarding we are requesting the government of India to make it compulsory in the high-rise buildings or even the flats, at least to have one AED. AED cost about 70,000 or 80,000, and it really saves the life. So we are all doing. We have started webinars. This is Brent Buttiger. This Brent Buttiger is our friend from Germany. He is one of the members of LCAR. And these are all the things we need. AEDs in cinema halls, bus stands, gyms, sport grounds, swimming pools, so many other things. And EMT should be available there everywhere. And not only EMTs, we need lot of bystander, this volunteers to get involved in this work. Then we can definitely make every citizen a lifesaver. And this is one doctor actually when she was going to the hospital, one fellow fell down and went into a cardiac arrest. She saved him, and taken to the hospital there. So this is a Kalpesh Shah, you will be knowing Mumbai. There is a cardiac arrest when they are doing in the gym. Luckily, they have a AED in their gym, and he has done. And this is Shraddha, you will be knowing. She got a good prize, photography prize, by the WFSA. And anything, whenever there is an incident, like saving a victim or anything, please report to us. We will definitely record them. We will try to honor them. We can also conduct some meetings of the lifesavers, not only lifesavers, the people who have survived. We can make a club and make them to talk and let the propaganda go through their mouth. This is I have introduced swearing in after the Bcls program, and that telling that a pledge that we will work, and whenever there is an emergency, we will work and all those things. This is in Koppam Medical College, north of Andhra Pradesh. And this is all the Make in India program. I've covered it a little fast because of the time constraints. Thank you very much. Thank you.
Thank you very much, sir. So hats off to your work towards the human mankind global work. Now I request Dr. Rakesh Garg sir to kindly proceed for the same.
Thank you so much, ma'am. Thank you for this opportunity. So coming to the next session with regards to the updates of the Ircf guidelines.
You can share now. I'm out.
Yes, sir. Sheetal ma'am, is the slides visible, ma'am?
Yes.
Yeah, thank you so much. Thank you once again, the leadership of SAMS, for taking this important session of the guidelines CPR from our own country. And when we talk about the evidence, I'll just take you through some of the aspects which Sir was also mentioning. When we talk about the global concerns and the low survival rates, it quite varies. If you see the survival rate after resuscitation, it is as low as 2% in some countries and almost around 50% in some countries. And on average, if you see the Asian countries, it is 1.5 to 36%. So it's quite varied. And the reason are many, maybe the lack of awareness, the lack of infrastructure, the lack of training. And this is what we can contribute to a certain extent so that the survival rate or the bystander CPR increases and the survival rate will also increase into our population. Sir mentioned about the international guidelines, which we had from different countries, and the reason why ILCOR is putting as an umbrella for all councils, because there are some infrastructural and geographical variations that are required, and that is what the 8 councils across the world try to bring about something which comes under the ambit of that particular geographic region. And IRCF being a part of it, we have taken it forward for our own guidelines, which are at times evidence-based, but at times also it is based on the expert opinion, because we do not have very robust evidence coming from India. And we have tried to extrapolate the evidence from Asian countries to come up with guidelines which are more suitable to our own population. But why do we need our own guidelines? The reasons are many. And if you see the infrastructure, there are hospitals, something like this, or something like this. From basic to advanced, we have very varied infrastructure. And that's why these guidelines came up, where we tried to put them according to the Indian scenario, the code links, which was made quite different for basic layperson as well as the advanced one, wherein we have tried to incorporate the essential understandable links, which remains to be the core priority, while not only teaching training, but actual conduct of CPR during the patient's management, so that outcomes become much better. And these were put into the framework of algorithmic approach, where they have come forward so that a stepwise approach can be provided training and actual resuscitation, so that the outcomes becomes better. Now, when we talk about the evidence of CPR guidelines across the world, because sometimes the evidence are not so robust in certain aspects, because doing the research becomes a major issue, and that's why the data which is being collected are retrospective data or observational data, and those are becoming the evidence for resuscitation across the world. If you see, when we say the evidence is, we have, say, more than 5-6 studies, good standard studies, good quality studies. We do a meta-analysis and comes with a conclusion. But this type of conclusion is not very strong in the resuscitation. For certain things, yes, there are. For certain things, yes, we do not have. And that's why we are just putting up the best opinion that is coming up, mixing everything so that we can take care of. If you see the recent update that is happening across the world, when we talk about CPR, it was more of an algorithmic compliance. We have a stepwise approach, and we say we need to go stepwise, one, then this, then this, then this. So this means this was algorithm compliance, but what we actually want in today's world is a physiology and system-driven resuscitation. This word is very important when we talk about any evidence in CPR across the world, including India. When we say CPR, what we are trying to do is try to recovering and retaining the physiology of the patient. And when we try to retain the physiology, a system is required. It's not a one-person management plan, but a system-driven resuscitation is equally important, because time is value here. When time is a value and multitasking has to be done and multiple stakeholders has to be involved, so this becomes a system-driven resuscitation. And that is what IRCF is always propagating, that we need to generate more trained people across India so that we can create some system. And those people, when follow a single guideline, they will be talking to each other in a more scientific language, and the outcome will improve. Each resuscitation guidelines has its own importance, significance, but speaking the same language is equally important in a particular country. And that's why this philosophical shift in CPR updates is happening across the world. And that's why IRCF also strongly builds up that we have to create a system across India so that our population gets benefit. So it's not just a rigid sequence of steps, but the emphasis should be on physiological targets, system readiness, and outcome-oriented care. And that's what we need to look for, what we can do. And for this, we need a high-quality CPR, early defibrillation, and coordinated systems because it will increase the survival. High-quality CPR, we have to have uniform teaching, training method across India, which IRCF is propagating. Defibrillation, yes, even the government of India and various NGOs are trying to put up AED across many places. IRCF has tried to train many people at the airport authorities, at the parliament, and at various places. And as you mentioned, in the school also. The purpose is that we want to have a system where majority people start the CPR within the first minute of cardiac arrest. And once they start it, the high quality has to be maintained, and that's what's the quality of training matters a lot. And for this, we need certain evidence, and that's why IRCF is also taking a step for registry data, because we need to understand that if the survival rate is not increasing, what is the issue? Are we not providing CPR, or is it a late CPR, or it is the quality of CPR being affected? And this shift is important, which is coming from across the world, ILCOR, that the CPR should focus more on physiology and system-driven resuscitation. Now, I'll take you through some of the important evidence which has come in picture in the coming years, and what are the strengths in the IRCF. Now, when we talk about the hand position for the chest compression, this is again an important point because the Indian physique is quite different from the Western population physique. And that's why the heart may not be located exactly at the same point where we conventionally do the chest CPR. For example, when we say intermemory line or internipple line. Now, there have been a couple of good studies which has come up, which talks about the optimal position of external chest compression. And people have tried to identify the areas under the sternum using CT scans, MRI pictures, transesophageal echocardiography, and they have tried to identify what exactly structures needs to be there under the sternum. And we understand that when we provide chest compression, compression should be on left ventricle, not at other places. And this is what has come quite interesting. They have tried to identify the CT pictures. They have identified the structures. If you see this picture, the picture A stands for the internipple line. Picture C stands for the sternogyphoid junction, and picture B in the middle is somewhere in the between. Now, if you see the first picture, picture A, which is internipple line or intermemory line, the structures are not the left ventricle. They are maybe the pulmonary artery or the aorta part structures. This means they are not on the right compression point. If you see something between the internipple line and sternogyphoid junction, yes, we are able to capture the left ventricle. If we go lower down the sternogyphoid junction, we are again missing it. So now these studies becomes very important, and they conclude that only a small proportion of ventricle is subjected to external chest compression when CPR is performed at internipple line. And this is coming from an Asian population, which is more corresponding to our Indian population. So this means internipple line may not be the correct place because left ventricle is there in very small subset of population. Another study where they try to identify the internipple line, and again they did a nice CT scan pictures and they try to identify which structures lie at which part of the chest, and they also find that the internipple line may not be the correct place. It is somewhere between the internipple line and the sternogyphoid junction. And that's why when we were talking about the IRCF guidelines based on this, and they also identify the distance that it is approximately 3.3 to 3.4 centimeter distal to the internipple line. So this is almost somewhere in between the internipple line and the sternogyphoid or gyphoid process. So this is based on what we have tried in IRCF to relocate the correct position where we are compressing on the left ventricle. Another study where they have tried to identify using transesophageal echocardiography, and they identified that most of the time the structures which were there were not exactly the left ventricle, but there were different structures which were not relating to the left ventricle. So this means the most effective or efficient site of the chest compression would be somewhere more caudally than the intermemory line. Another study which talks about the lower side, which came from Singapore, and they want to, when they try to identify the lower half of the sternum, they also identify that when we go more distally towards the gyphoid process, again the compression value is not good, and the risk of injury to the abdominal organs happens. And that's the reason that the IRCF takes, based on this strong evidence, identified that 2 fingers above the jiffy sternum is the safest approach in Indian population for compressing the left ventricle, and so that the outcome becomes much better. And similarly, when we try to talk about the compression and decompression, this side also becomes much better. And we need to identify another evidence which is strong through this picture is that when we compress, we have to release it, because organ perfusion and myocardial perfusion happens in both the aspects, systole and diastole. So compression and relaxation should be sufficient in these patients so that the perfusion happens to the heart also. Another important aspect that finds change in country to country. Now, this is the very conventional coming from AHEs and ERC, with the talk of the reversible causes 5H and 5Ts. Absolutely, these are important to understand that these 10 causes are important for resuscitation. But some of the causes has been removed from those because they were not very common in on the Western population, and that's why we try to include them. For example, the head injuries. Head injuries are quite common in India. India is a diabetic country. Glucose impairment is very common. India is becoming a diabetic country, and almost 1/3 of population are expected to be diabetic. And that's why we should be looking for this evidence. And that's why when we talk about reversible causes during the CPR management, we have to expand our usual causes so that during CPR we can target them, and then only the outcome will become better. And that's why the hit the target includes all those aspects when we try to manage these patients who have gotten cardiac arrest. Similarly, when we talk about the variability of resources, this was an interesting paper that was coming from Ilcor, where we have tried to analyze the clinical outcome from outside hospital, out of hospital cardiac arrest in low resource settings. And this was an interesting paper wherein we tried to incorporate opinions from a different country, different resuscitation councils, and it was published in Lancet Global Health, wherein it was realized that the difference of the existing infrastructure and the resources available, there cannot be one way of doing everything. And that's why if you see this chainmail survival, if you have seen the link code links, which we also mentioned in IRCF, they are in a single framework of one each. But if you see the Indian infrastructure, the topmost of this picture includes those major framework. But on the lower line, there are many circles which includes many aspects. For example, if I put AED, now AED 10 years back, it was not available, but now it's available, and it's available in some of the states only. So this means if it's available, we need to incorporate somewhere into the system, and that's why there has to be some flexibility of improving upon. IRCF is working on those aspects also, and maybe in a near future, we will try to come up in those amount of flexibility. But for teaching training purpose, we have to be very clear so that there is no confusion. So when we create guidelines, it has to be clear, straightforward, start-wise approach. But when we need to understand for policy matters, this type of chainmail survival link is very important, which has come from. The another important evidence which is coming through the management of patients as advanced drug therapy is the vasopressors. Now, there were a lot of confusion and the evidence was not clear. But what has come up in the recent evidence is that the focus was shifted from which drug to when the drug is given. People were talking about vasopressin in the earlier days, and then comes the phenylephrine, the epinephrine, the adrenaline, and so on and so forth. But it was clearly mentioned that early epinephrine for the non-shockable rhythms is the very important aspect. And the judicious timing for shockable rhythms after initial defibrillation attempts was also focused. And they realized that the early administration is very important. Delayed or indiscriminate use may worsen microcirculatory flow. Sometimes the overdose of the time is too less, they will cause a lot of microcirculatory changes, and the outcome may not be so good. That's why the epinephrine should be given at the earliest, and it should be given while the chest compression is ongoing, so that it can be circulated rather than stacking into the venous system. And that becomes very important. Similarly, the airway management. As an anesthesiologist, we are comfortable, but during CPR, all are not anesthesiologists, because when we talk that CPR should be started in 1 minute, it can be at any part of the hospital. Everybody should be trained and they should start it. So the best device is still controversial because some people are comfortable in one device, some are other comfortable. So there is no option to choose one device. But yes, it is mentioned that optimal ventilation using an airway gadget without interrupting chest compression is the best device. So whatever appears to best, you can go about and do it. And there have been a de-emphasis in the recent updates of the early advanced airway. As anesthesiologists, yes, but there is no mandate for early intubation. Stepwise airway escalation is preferred now, and emphasizes on avoiding CPR interruption is much more important, because stopping the CPR will lead to more amount of catastrophic and perfusion-related injuries to the organ system. And hence, multiple trials shows no survival advantage for early tracheal intubation. If you are happy with supraglottic device, go ahead. If you are happy with bag and mask ventilator, go ahead. And more recently, people have started using HFNC, though we have not incorporated into guidelines because the things are emerging. But in future, yes, HFNC will also be a part of airway management, because passively 60 to 70 liters FI of 1 will also be equally important to increase the apnea duration with better oxygenation. So this is what is coming up. But yes, airway strategy should match provider skill and context, not a particular one. Capnography. Now, this is again an important aspect. We have been struggling in the past about use of capnography in perioperative period, but it has come up very nicely for even for resuscitation for many reasons, because EtCO2 correlates with cardiac output, and the quality of cardiac output depends upon the quality of CPR, and hence the quality of CPR can be judged from these physiological parameters of end-tidal carbon dioxide. Not only this, if there is a sudden increase in EtCO2, it indicates return of spontaneous circulation. A very good sign for this. And persistent low EtCO2 is also an indicator when to terminate CPR. If in spite of your good quality CPR, the end-tidal CTO is not good, it's persistently low, it's an indicator that this resuscitation may be futile and we can take a decision to stop it. Oxygen titration after return of spontaneous circulation. Again, important aspect, because we know oxygen is important, but giving more oxygen can cause, after resuscitation, hyperoxic damages. And hyperoxia increases oxidative injuries and worsens neurological outcomes, because there will be some hypoxic injury. So that's why now the resuscitation, as I mentioned in the beginning, is system-driven, physiology-oriented. It's more brain-directed resuscitation now. And hence, we need to direct normoxia and monitor oxygen saturation to keep it somewhere 94-95%, not 100% for all the patient, to prevent this. Defibrillation strategies, again, an important aspect. It will be discussed in detail in the subsequent section. But now we are moving forward. When we give an energy of 120 joules, which is required for India, it has to be increased further, and details will be there. But what we have come up with something called vector control versus double sequential external defibrillation. So these are the newer concepts which has come up, that if the resuscitation is ineffective, by putting the standard conventional defibrillation and giving 120 joules, 150 joules, and 200 joules, we should attempt changing the vectors so that heart can get good energy. If it does not work, we can see double sequential external defibrillation. This means using two defibrillators to provide energy so that the refractory heart can get more energy, and there may be a possibility of converting into a say a normal sinus rhythm, and hence return of spontaneous circulation. So this vector change is also becomes important. Coming to the other aspect of TTM, the targeted temperature management. Yes, we agree that hypothermia is required for preventing further neurological damage, and this is one of the important aspects. But then it requires a lot of input. What is now coming up is that shift from the mandatory hypothermia to strict fever prevention. Yes, hypothermia is important, but hypothermia also has its implications. It can damage, if uncontrolled, it can lead to many of the physiological changes. We also understand that post-resuscitation, fever also affects the outcome. So when we try to compare both, the evidence is that we should try avoiding warming the patient and try avoiding the fever happening in this patient. So hyperthermia must be avoided. There is always a compensatory response. If you see the patient after resuscitation, a lot of inflammatory cascade will happen, and this patient will show fever. this fever can affect the neurological outcome, and hence it is mentioned very clearly that we should attempt preventing fever. If we have a controlled environment for hypothermia, go ahead, but we should not be very strict about mandatory hypothermia for all the patients. So this is in brief, and what is coming in this year and maybe next few years, the Elcor is coming up with this artificial intelligence coordinated CPR activities for teaching, training, and real time. I'm sure that in the next 2-3 years, we will be coming forward with some robust data of using AI for CPR. That becomes important, but simultaneously, the recent updates that are coming from Elcor and they will be incorporated in the IRCF guidelines in the coming years is about the palliative populations also. Now, if you just summarize the updates which are coming from Ilcor right now, they are more focusing on physiology. They are more focusing on system-centric. They are more focusing on a continuous competence training rather than one-time training in 2 years, and more community ownership. And that is what is being done by the resuscitation councils across the world. Termination is also coming important nowadays. When the advanced care planning has been adopted by Supreme Court of India, and it is being forwarded by the government of India also, we also now will be integrated advanced care planning into the system. As and when the things evolve in India, this will be a part of CPR, that in which group of patients we should be thinking of advanced care planning and terminate the resuscitation in case if we have some written things. So this is in brief. There are many other things, but because of shortage of time, I've just tried to put up some of the important aspects. I'm sure there would be some questions. We can take it up, and the evidence will be started coming up. And I'm sure that the year 2026 to 28, these 3 years are quite crucial for various technology-based or technology-driven CPR activities which are coming up. So let's see how the next 2 years comes up with the effective involvement of technology. But at this junction, I urge each one of you that you all are equally important for providing a safe, good quality CPR. So let's come together and create a system where 100% of laypersons are CPR trained. 100% of layperson are CPR trained. And the government of India is also taking this initiative. Let's join hand together and make our country safe, make our country CPR trained. Thank you so much.
Thank you very much, sir. Excellent talk. And SAMS is really today honored to listen from the horse's mouth, a legend of evidence-based, especially studies. So now going to the next lecture. Now I invite Dr. Ashish Diwan sir for his talk.
Thank you so much, Dr. Shetal, and I probably from my heart thank the leaders of science and the colloquial organizer that you and deeply thank you for including IRCA guidelines and content in this wonderful and yes, am I audible and
Audible, little louder, everyone.
am I audible, visible?
Sir, you're audible, visible, but your voice is a little slow,
Okay.
sir. If you can increase a little volume, sir.
Voice.
Chennai, one of the medical college right now. Anyway, I'll try to speak little louder.
Okay, okay.
Let us see that. First of all, both my previous speakers had a time constraint, but I'm sure I will not have it because Chakrarao sir, our dear chairman, has already highlighted the magnitude of the problem of training we have in our country for years, as well as he has already talked about the journey of IRCF in last 7-8 years. Thank you so much, sir. And Rakesh, as usual, as wonderful, he has given very good evidences for the guidelines which we have changes in the ILCOR and in even Indian guidelines. So I'll try to focus briefly to the recent updates which we have taken over from the ILCOR guidelines. They are not very many, but I'll try to highlight them. Now, as Chakrarao said, we are a member of ILCOR, which is International Liaison Committee on Resuscitation, and we follow ILCOR for our guidelines. Since 1st June 23, we are part of ILCOR member. and we are highly of resuscitation science internationally. And thanks to Dr. Chakra, Sir Rakesh, and many other people who are the member of either the task force members or the committee members from India, who all visited us in the newer change in guideline meeting in Rotterdam, Netherlands last October. What I want to tell is that ILCO does continuous evidence evaluation since 2017. So every year there is an evaluation going on, and there is a process. However, they give the full draft only at the end of 5 years. So the last draft, which was 2020, we had studied very well. They have updated in 2025 recently in Netherlands meeting last October. So there is a process of update which I'll briefly tell you about. There is a topic of proposal. We call it by cost. They take the population, they select the subject, there is an intervention, the management is decided, there is a comparison of the older technique, and some outcome is finalized. And such way, this is the process how a study is done, multicentric, with a lot of review literature, and a study is designed and in a particular time frame, and that's how the outcome comes. And mostly in resuscitation, the outcome depends upon the return of spontaneous circulation, survival to the hospital and discharge in 30 days survival, or survival with favorable neurological outcome, because judging the quality of resuscitation. So these are the outcomes which are measured, and this how with this lot of studies they come with the process and they come with the draft. And once these are done, collected, there's a systemic review by task forces. And I'm very happy to announce that there are many people who are in task force and committee members present here. Now also Dr. Said Moid and few more. They are part of the committee, and they all help us out to have our own voice in ILCOR, and the science which treatment comes with that, and they do a public comment, they do an announcement, they put the draft on the website and are made to comment. It stays for 3 to 4 weeks only, and we give a comment. From that, a final draft is created at the end of 5 years. Multiple guideline meetings are carried out almost every week, one at odd time in the day also the meeting takes place, and they are finally suggested to all the member councils of ILCOR. And member ILCOR doesn't give the guidelines. ILCOR gives the suggestions, the strong recommendations, and a draft is given to all the guidelines to adapt and make change. Different ERC will do something different. New Zealand, Australia will, depending on the requirement of the community in their area. And we follow these guidelines, and we try to fit it everything to our Indian and Asian population, described particularly for the placement of hands while doing the compression. Every time there are some knowledge gaps created, and they are transferred for the next cost. It has already been started now, because already 8-9 months have gone after the release of the 25 guidelines. Ircf has updated the guidelines recently, and we are very fortunate that whole team was working for last 6 months under leadership of Chakrao sir, and we'll be coming up very shortly with the newer manuals, which Dr. Vivek is also going to talk about soon after this lecture. So let us try to understand where we have made the changes. Now, I don't need to give the evidences, because Rakesh has given enough evidences for the most essential part of the component of guidelines. But I will talk about the changes which has ever taken place. So first, we start with the adult. Now, in basic cardiovascular life support, very little change has taken place. And the major change was in the choking, foreign body obstruction. Now, actually, we already had 5 back blows in the guidelines, but internationally it was not existing. So the changes took place in choking, in compression technique in infant, the energy selection for cardioversion, the placement of deep vibration pads, and some special situations that we have added in our manual, which once it is out, you will be able to see it very well. So I'll shortly, briefly describe all of them. There's not a very big list, so I will not have the time constraint, Shital ma'am, so reassure you. First, the adult choking. And up till now, we were teaching only abdominal thrust. So 5, 7, 8, up to 10 abdominal thrusts we were teaching to, and internationally everyone was teaching. But that has been changed now. And we do 5 back blows and 5 abdominal thrusts. Now, we do start with the 5 back blows and then subsequently immediately do 5 abdominal thrusts. And if you don't get the outcome, you repeat 5 back blows and you do the 5 abdominal thrusts alternately. Now, back blows between scapulae create a pressure wave and vibration, and it resolves the issue in many cases. So you may not have to do 5 abdominal thrusts. Take a plastic bottle with a cork. If you give a jerk to the plastic bottle and you press it, the cork pops up. That is what the principle of raising the abdominal pressure is. And you actually raise the thoracic pressure. Now, the data suggests that abdominal thrust gives about 60 to 70 success rate. 5, 7, 8 blows alone gives 50 success. While if you combine 5 blows and 5 abdominal thrusts, it reaches to about 85 to 90%. So that's a real cut advantage, very much evidence-based, that 5 abdominal thrusts you do alternate gives a much better success rate and outcome. So that's why it got with a lot of evidences. It came as a change in the new guidelines from new suggestions from ILCOR, and which IRCF also has adopted. Problem is only abdominal thrust. If you keep on doing, there are high chance of refractures, and this has happened few times, liver or spleen injury or vomiting. So the aim of doing alternate is not only increasing the outcome, but also reducing the injuries. Now, if you recollect our elderlies and our common citizens, they have a natural instinct. If somebody chokes, they give those. And they never understood the science. But now with the evidences and the science guideline that you give a 5 back blows and give a 5 abdominal thrusts. So we have started following our elderlies who were doing it for years. Then the next change came was for the compression in an infant. We were used to teach 2 fingers over the lower half of the sternum and 2-finger technique with a single rescuer we were teaching. Now, what has been observed, and it took very long time after they made this 2 fingers technique available in all the guidelines and the evidences came, it took many decades to change it. The problem is there's a shallow depth, less consistent rate. The average rate calculated when you try to do 120 with fingers, it reaches to 110. There's a lower perfusion pressure observed, and we get tired, our fingers get tired. So the 2 fingers was challenged, and it was observed that when 2 rescuers are there, we were used to teach with the encircling hands with 2 thumb technique, which is a preferred technique even when you are a single rescuer. So 2 thumbs encircling chest gives a deeper and stronger compressions, consistent compressions, and generate higher pressure, blood pressure to perfuse the vital organs, brain and heart particularly. So that's why this change came, and we have already adopted it before 6 months actually, the moment it came, because some changes you have to make immediately. Some are suggestions, some are strong recommendations. So another change came in the cardioversion. Now, for particularly atrial rhythms, particularly the SVT unstable patient or atrial flutter, we were starting with 50 joules, considering there is a less injury to the skeletal tissues and myocardium with a lower energy we use in our population. But it was extensively studied across the world, and in Western world, it was decided that you start with 200 joules only. Why we give a lesser dose? The reason is you get a higher first shock success rate. But we are giving 120 joules for even defibrillation in our Asian population and Indian population according to our guidelines. So we stuck to that, but we have reduced that 50 slot. So we start with 100 or 120 joules and escalate it to immediately, if there is no outcome, to 150 or 200 joules. With that, probably one or two excess shock we give with the cardioversion, our incidence of burns are reduced because number of cardioversions are reduced with that. So recent update says that you should start with a higher energy only. There's a less injury in spite using higher joules because the number of shocks are reduced. Then minor change came for the defibrillation pads, as Dr. Rakesh also explained, and he explained the rubber sequential also, and the vector of the axis we give when we give the defibrillation, and the placement of the defibrillation pads in such a way that you get the best coverage of vector passing through the myocardial axis. And the first change recommendation was that right pad you put right side of the sternum and below the clavicle, but the left pad which goes in the mid axillary line just below the armpit. And now this has come up in our guidelines, and this is a strong recommendation that you get a better vector and you can do a better defibrillation with this axis. And double sequential is still under process. It has not come in the guidelines yet, but maybe process of studies and everything is going on. In fact, it started originally in Denmark with the hypothermia patients, that they were resistant to the shock. So they started giving 2 shocks in 2 vectors. But as a recommendation with the evidence base, it has yet not come in the guidelines. Probably it may come in the next guideline. Few special situations like CPR in pregnant lady and infant or child were already there in our guidelines. We have been extensively teaching for last 8 years, and there is no much change in these guidelines. However, this time in our literature, in the manuals, in the book, we have added CPR on dental chair, prone CPR, drowning, I'm sorry for the spelling mistake, over the head CPR, and snake bite. Now, however, these situations are slightly different, where actually the principles of resuscitation, CPR, and guidelines are same only. But we may have to modify certainly on the excess treatment and management we do with different situations. So once this will come up in our guidelines, it will be in the benefit of all the readers of our guidelines, which will probably will have in our hand in the next month. And these are the minor changes which has taken place in our guidelines in this 25 draft suggestions from ILCOR. We have strictly followed it, and we will percolate it down to the all CRTCs and all the instructors soon with the webinars, and give you evidence-based education for this purpose. So actually, there are very few changes which has taken place from 20 to 25 in our guidelines, but they are very, very essential, and we have updated it very well and easy to implement. So very useful to our society. Thank you so much for inviting me, and all SAMS leaders and Dr. Sheetal Dalal.
Oh,
I'm really obliged that I'm here today with you, all of you.
thank you, sir. So it's really to hear from you. You are enlightened us about the recent advances for the successful outcome. And now I request Professor Dr. Syed Mohit sir for his deliberation.
Is my slide visible? Hello?
Yes, sir.
Hello?
Yes, sir. Yes, sir.
Okay.
Yes, sir.
Okay. Greetings from my university, Al-Karim University, which is in Kathiar, and good evening to all of you, all the participants. I know a lot of people are there who are aspirants to be an instructor, and we encourage, especially ISF is encouraging most of the people to become an instructor, and we would love to entertain you or encourage you to become an instructor. So how to become a good instructor or trainer is one of the most important things, because we need to build competence, confidence, and teaching skill while you're becoming an instructor. So the learning objectives will be to explain the qualities of an effective CPR trainer and create a safe, learner-centered classroom. Teach CPR clearly and confidently. So once you are yourself a good trainer, a good instructor, then only you can teach them, the others, how to become an instructor. Teach CPR clearly and confidently. Most important is you need to be confident. So you need to know the science of CPR. Use modern evidence-informed teaching methods, like we have been discussing since last 2-3 lectures, and give constructive feedback. So most importantly, you need to be interactive and be part of the participants, not the other side of the table, within the same participants. So conduct effective CPR practice sessions. So people should at least be able to recollect, recognize, and give a feedback that what has been their difficulties while getting the training. Assess the learner's knowledge and the skills at the same time when you're trying to give them a training. And the most important is the golden rules of CPR training. So so the most important thing is you start with a very good confidence, and that is very important while you're trying to become an instructor. And the good trainer must first be a confident, accurate CPR provider. Now, this is very important. Unless you are a good trainer or you are knowing the science of CPR, you will not be able to teach the others, because there will be a lot of questions, a lot of interactions where you need to be very confident in answering all those questions which is being put forward to you. So start with the strong and clinical competence, and most important is know the science, understand current BCLS, CCLS, or ACLS guidelines and why each step matters. That is very important. Because we need to describe them, explain them, why are you doing this technique, why are you going for this skill. As Rakesh was saying, we need to change, we have changed our system of training. I mean, we have changed the to overall CPR guidelines as per when we talk about the international guidelines. So master the skills, perform compressions, ventilation, ADUs, and team actions correctly. Stay current. That means you need to update yourself, review guidelines, updates, instructors, go through the instructor manuals of our IRCF guidelines, and then see what are the local requirements, and you can change accordingly. So develop the mindset of a teacher. That means you need to be a good teacher. That means you need to always understand that what a teacher needs, and then only will be able to teach the others. And your job is not only to show CPR, it is all to help the learners become a capable rescuers. So naturally, the outcome is very important. Whatever a person can learn CPR, but he has to give a good outcome, that the patient should survive, the victim should survive. That is very important. That's the most important thing. And so naturally for them, we need to practice. We need to know the science behind it. So explain simple, clear language, what the language the patient should, the instructor should understand. At times you can use a local language, you can use their colloquial language as well. Demonstrate, show the exact correct technique. The most important thing is, otherwise your outcome will not be good. As you said, that where to place a hand, how to go up with back mask ventilation. They all have a specific technique, and you need to follow those guidelines. As per the technique, you need to follow those guidelines as well. So demonstrate them, show the correct technique, practice. So practice makes a man perfect. You know that very well. So give repeated hands-on timing, repeated hands-on, so that if they're making a mistake, don't discourage them. In fact, encourage them, let them know that you are doing right, but you need to just go a bit more than what you're doing. So that is very important. So specific, respectful feedback. That means, yes, that I said, you tell them that this is, you're doing it very nicely, but you need to just improve a bit more. So check the competence objectively. So we need to check them that whether they're doing it correctly or not. That is very important. So create a safe, learner-centered classroom. That means there should not be any hesitation from the learner. The learner should he should be very open. He should be confident that, yes, if I ask a question, I will not be discouraged. I'll be reverted back with an encouragement. So that is what is very important. You need to create an atmosphere, environment, or ambience within the classroom which tells you that which the patient, the victim, the learners will open up. Only when they open up, then they will be able to learn. Otherwise, people are, if they're hesitant, they'll never. So you have got to be very friendly and got to tell them that this is what is to be done. But at the same time, you should maintain the decorum. Too much friendly is not important, because otherwise the other person will not be able to learn. You need to be strict at times. So introduce yourself and learn the learning goals. Avoid overloading. Do not give a lot of informations at a time, because everyone has a capacity to learn. Everyone has a capacity to accept it. So you have to let the people digest whatever you're saying. So the time has to be given, and you can go for a repeated session so that you give them at a time. Don't overload the patients with the learners with a lot of informations. Don't always, very importantly, avoid embarrassing learners and criticizing their mistakes. So this is very important. You should never criticize, because otherwise they'll never open up. They'll feel discouraged. They'll try to avoid themselves. So this is why you got to encourage them. You got to tell them if they're making any mistake. Tell them, okay, you're doing good, but you need to just improve a bit. You need to do it this way. So that is what is very important. So normalize the mistakes. If they're really making mistake, don't highlight it. Don't highlight in front of everyone. You can take them separately and tell them, see, you're doing good, but you need to also do this way. So that is also a better way of telling them. You can also, use inclusive language and demonstrations. So naturally, you include everyone. You don't just say, you never should highlight any one, but if you're teaching in a group, don't highlight any particular person that you are doing good, others are not doing good. So that is a very wrong way of teaching. You should tell all of you are doing good, but some people need to improve a bit. That's a better way. Keep learners active. So whenever you're teaching, I know you'll be trying to teach. You'll do some actions, but at the same time, you have to give them. You have to make them learn. So they have to see that whether they are performing. So don't make them passive. They will make them active. That is what I'm saying. It's a both-way interactions and both-way hands-on training as well. And encourage questions and pray. So you can ask them, did you get my point, what I'm saying? Are you with me? Are you in this in the classroom? Are you getting my what I'm trying to tell? Do I need to explain it again? So this is what are very important. You need to time and again ask them, tell them, because they are learners. They are trying to become an instructor, so you've got to tell them. And if they have any questions, it's always to encourage. Supposingly you tell certain things, and you can take a feedback, tell them that, did you get it? Now, let me ask you a question. Why did I go with this technique? Why didn't I go with the other international technique? So you need to tell them and take the answer from them. So very importantly, build confidence through repeated practice. This is very important, right? So demonstrate skills clearly. That is very important. As I said, you must know what you're teaching, which guideline you're teaching, whether it's a BCLS or a CCLS, and how BCLS goes, sequence goes, how ACLS, CCLS goes, sequence goes. This is very important. Where to limit yourself when you're teaching calls. It's not that you're trying to overlap calls with the BCLS. So this is and you should always keep that in mind when you're going and try to demonstrate the complete skill once, and then only you ask them to perform it. So let the people practice in front of you, and then you try to get a feedback. So breakdown means explain key actions in a small steps. So as we know that in our guideline, we have a stepwise fashion, and any CPR guidelines or any guideline, they have a stepwise sequences. So naturally, you don't try to overlap one sequence with the other. Break it. So this is what you just learn how to maintain an airway. That's it. So how to maintain an airway? Don't teach airway maintenance along with back mask ventilation. First, let them know how to maintain an airway. Once they know how to maintain an airway, then you go with the back mask ventilation. So break your steps so that they can easily accept, it becomes palatable to them, and they can acquire their skills. So this is what, and obviously feedback is very important. Correct errors quickly and specifically. Whenever you see that they are doing a technique, they are not giving 3 seconds for a back mask ventilation. Always say, no, it has to be the 4th step has to go for a cardiac compression. So that is, you have to, if they're doing it wrong, you correct them immediately. Don't think that at the end of the time you'll try to correct it. So then things will not be working. So coach with high quality feedback. Feedback, as I said, is very important. It's positive. Start with positive feedback. Your hand position is correct, but your rhythm is consistent, but you need to improve yourself. That means you're giving a positive feedback, and then don't discourage that. Even if they're doing wrong, you try to tell them you need to improve better. I'm telling you repeatedly, because this is how you need to train yourself, so that you have a mindset of teaching, and the learners who are taking from you, they don't get discouraged. and name the exact action to change. That what, supposingly I'm going for a chest compression and I'm going to have a recoil, chest recoil. So what is that? Is it, what do you mean by chest recoil? Why do you want to go for a chest recoil? That exact action has to be told to them, and then that is why they'll understand. Otherwise, they'll, after doing a chest compression, they might remove their hand. So you need to tell them, don't remove that your hand. You, once you've identified the location, you keep your hand there, and then you have to go for a chest recoil. So this is what you have got to explain the science behind it. Let them try again and again. So let them, if they're not getting it, let them do it again. Let them say that, oh, tell them that you can go it again, practice it again. So this is what is an example. So use modern evidence information technique teaching methods. People, you don't, because we now have videos, we now have PowerPoint presentations, we now have demonstration. Even the NMC, they are going for competency based education or skill based education. So naturally, you also can have even the teachers training, or even whatever we are taking a teachers training. There also we are being told how to go with the evidence based information teaching methods. So use those recent techniques, because your learners, they might be also having those techniques, and they'll come back with those they will expect that you also teach them with the same techniques. So feedback devices, objective information can help learners improve CPR performance. Rapid cycle practice means short cycles of attempt, feedback, repeat can accelerate improvements. That means you got to go for, time and again, you got to practice and let them do time and again, so that they can come back, improve their assessment, and come to the accurate method of to go for a CPR. The simulation methods are again a very important technique which we have learned, we have come across. Simulators are something you give a scenario and tell them that this is, because we know that even the instructors, we have mega codes, we have scenarios. So when we talk about scenarios, give them the scenario and then make the scene realistic. You can also, role play. You can also role play, and then that role play, something which they'll remember throughout their life. So that is how you can also train them. So recent evidence and the recent techniques you have to adapt, so that they can learn the technique, and they can be confident, and competent will also come in immediately. So blended learning means combined self-directed learning with hands-on skills practice. You can also innovate that what you would like to teach, how you'd like to teach them. So assess competence, not just attendance. So most importantly, the instructors will be attending your session, but they will be physically there, but mentally they are not there. This is very important. You've got to assess whether they are really learning whatever you're saying. So correct sequence, effective teach technique, appropriate pace, and depth per current courses at standard, AD team actions when applicable. So these are something which you need to see whether they're doing it, whatever you told them, whether they've accepted it, they've learned it, and they're doing it accurately or not. Because physically they're there, that means their attendance is there, but they're not taking what we are saying. So that taking has to be there, and that is how you need to have a very good feedback and a two-way interaction. So always try to do, you can reset, you can reset, and then you can observe, you can compare, and you can coach as well. So it is a cycle which you need to do whenever you're teaching it. Always try to judge, to assess, and the common mistakes which they make, you need to understand, and you should keep in mind that these are the mistakes which they'll make, and you try to be very specific about those mistakes, and try to tell them. Don't make them embarrassed. Don't try to discourage them. Tell them that your hand is incorrectly placed. Your incorrect compression is there. These are the places where they will make mistake. So you need to tell them that this hand has to be here. This compression has to be this way. The inadequate compression is always the place where you need to know whether the depth is adequate, the timing means the rate is adequate, the recoil, chest recoil is there. These are the places where they will commonly make mistake, and you need to be very specific and accurately watch them, and then train them there only. So excessive interruptions should not be there, and most importantly, the correct placement of AD pads. Poor ventilation technique. This is a technique which probably is very difficult to learn, because ventilation and airway maintenance is something which is very difficult, and that is why in some of the guidelines we have removed it. Because unless you learn ventilation properly, you are going to cause more problem. You got to cause gases in the stomach, and that is going to be detrimental to the to the victim, at the same time your outcome of the patient. So naturally, you need to be very specific. Tell them how to go ahead with bag mask ventilation. And this is a very important technique. They will always make mistakes, so you can have to give more time to those places where you think that this is the place where they will commonly make mistake. Got to give them some time, got to repeat them at that particular technique, and then they'll come up to a better understanding. So the qualities of an excellent teacher has to be competent. They have to be very clear. The explanation should be very distinct that what you're going to tell them. Try to be very open, to be confident, and be very patient. Always try to accept, try to be a very good listener. That yes, tell me what is your problem, why you are not getting it. So that is very observant, whether they are doing it rightly or not. And patient, observant, very clear-headed, competent. You have to be very fair, in assessment, and very reflect to learn from every classes. You must also learn that whether you have done something wrong or not. So train for performance, coach for confidence, and assess for competence. This is very important for a quality of an excellent CPR trainer. So most importantly, to become a certified trainer, you have to be yourself a good instructor. You have to be an instructor first. And I know a lot of people are there who are aspirants to become an instructor, and we are encouraging them to become an instructor. So we would always want you to become an instructor, and for that you have got to certify yourself as per the IRCF guidelines. You need to see the manuals, the instructor course. You've got to take the skills, the monitoring, and evaluate yourself, and that is and then always update yourself as per the IRCF guidelines. So continuous improvement is very important. Don't be reluctant. Don't be hostile. You don't think that once you've taken a training system, you become an instructor means you know everything. So you got to always update yourself. So before you go for any class, before you go for any training, try to go through the instructor manual and see whether you have missed something, whether you still know that how to go ahead with the training. So this is very important. You have an instructor manual, try to go through that manual and then try to teach don't be very confident, and then you might miss something which yourself will be in a false position. So always, what went wrong? Well, what went wrong? So this you've got to analyze yourself. Try to retrospectively analyze yourself, that whether you have taught them adequately, appropriately or not. Did everyone get enough practice? This is again you need to know. And which skills was the most difficulty, and was my feedback effective? So you need to, once you've given a training, once you've trained an instructor, you also should assess yourself that whether you have justified yourself, whether you have satisfied yourself that the training system went right. So because you are building an instructor, and the instructor is going to subsequently train the others, and most importantly, if you're trying to become a provider, also you're making a person provider. That provider means he's going to save a patient's life, a victim's life. So he must be trained properly. Then only he'll be able to. So your training is most importantly dependent upon, the outcome of the victim. So then only I will say that yes, your training has gone well. So the golden rules of CPR training, we know it, that which guideline you're trying to speak on, which guideline you're going to go train. You're trying to make a provider. So know that the science of it, know the sequence of it, know the guidelines, show it. So once you know this, then only we're able to show those techniques and show the sequence of guidelines to your provider. Let them do it. Now, once you've shown it, they should do it. And once they've done it, watch it, that whether they are doing it adequately, doing it appropriately or not, and whether they're doing it correctly or not. And then then you might repeat it again. So most importantly, these are the golden rules to become a very good CPR trainer. And you need to always keep in mind that great CPR trainer doesn't simply teach a procedure. They develop confidence, competence, and readiness to act. That means the person whom you are giving the training, they need to be a very good provider for saving a victim's life, because your training is going to be an effective training once you are being able to give make a very good provider or very good trainer who's going to subsequently save a victim's life as and when required. So this is very important. So thank you so much. Once again, I would like to say that a competent trainer knows the skill, demonstrates the skill, communicates clearly, creates a supportive environment, provides meaningful feedback, assesses competence, keeps learning and improving. The goal is not just to teach CPR, the goal is to prepare someone to save life. Thank you so much.
Thank you very much, sir. Excellent talk, excellent insights, how to become a good instructor and how to become an effective trainer and how to give the effective training also. Now coming to the last lecture, now I invite Dr. V.A. Gupta sir for his talk.
Is my slides visible? Am I audible?
Sir.
Yeah. So good evening all.
Okay.
First of all, I'm thankful to Sam's leadership for giving this opportunity to talk about this section of the IRCF, how this IRCF system is working. As Dr. Chakra Rao sir said, the insight about the IRCF, Dr. Rakesh here talked about how we are going evidence-based. So it is not only the academic front, but we are just working to make it more comprehensive platform so that it becomes easy for anyone to become to do the provided course, and more automation has been involved in this system. And it is good that as an anesthesiologist, we are basically a born resuscitators because we are the masters of airway, which is actually in our core. We know how to administer drugs in case of emergency. We are tuned with every emergency drugs. And the most important thing, we are the people who are actually leaders during the crisis because we anticipate the problems in operation room. We anticipate problems in the intensive care units, and we address this even before the problem happens. We try to prevent it, and if unfortunately it happens, we manage it. And moreover, we do have this instructor skills, inbuilt instructor skill, because we are tuned for teaching on the bedside, in the operation room, while this surgery in progress, we teach and train our juniors. So how this will happen in IRCF? Once we join, we do the provider course. The first thing is to do the provider course. I'll go in detail of each one. And once you have done this successfully, you are eligible to become an instructor. And definitely, as an instructor, you can develop a CRTC at your own hospital, at your own center, where you are building up a training center. And definitely, we'll be talking about how to renew your instructorship or instructor card. So first, how to become an ACLS provider. We have to do a course. The course is now in the update with all updates. The course is being in the dual platforms. It will be in the hybrid mode. We will have some online talks, lectures followed by evaluation, and then we will have the online lectures, which are the real time, followed by a hands-on skill, which will be a 2 days course, where we will be more focusing not on theory, but on hands-on sessions, case scenarios, interactive sessions, and more focus on the skills. Then it will be followed by a written test, which will be MCQ, and definitely a practical skills will be assessed at the end of course. And in both separately, we have to ensure that we are securing 84% marks. And definitely the IRCF is very particular for the quality of the course. So instructor, faculty, and participant ratio 1:5, and we have the full structured system we have developed, that how a course will be conducted, what are the prerequisites, what are the things should be available. Once you have done the provider course, you are eligible for the trainer course or instructor course. If you have a zeal to teach resuscitation skills, and definitely you need some recommendations that you have performed very well during the your trainer provider course. So this will be again an online sessions. All teaching materials will be available online, so you can read all instructor material, and it will be followed by a 4-hour session with the faculties, and then followed by a 1-day full course where a simulation, debriefings, and moreover presentations. You'll be asked to do presentations so that are how you are going to teach it, so that it will allow to make you a better instructor, as Dr. Mohit was describing the instructor. So the senior instructor will help you to become a better and better trainer. And once you become a trainee faculty, you have to do 3 supervised courses within a year time, and so that you become a full instructor. everybody will be instructor, but definitely a responsibility will be added every 5 to 10 years, and accordingly, you will be given positions in the IRCF. How to make a CRTC? This is very important. Once you are an instructor and you are willing to develop a CRTC in your organization or in your hospital, you have to have certain prerequisites like a certain mannequins, which is easily available in our systems, especially for the anesthesiologist. We should having some defibrillators, some simulators, these ACLS mannequins, and airway management system. So usually it is very easy for us to have these things. The only thing, the CRTC, it will be a single point to contact with the IRCF, who will be conducting the courses, who will be organizing all the activities through the CRTC. But one CRTC will be at least performing 3 ACLS courses every year, and it will be re-accredited after every 2 years. So the CRTC will apply that we have the following equipments, we have the whatever prerequisite is already described will be available on our websites, and you can complete those forms and complete your prerequisites, and you can become a CRTC. So it will be renewed after every 2 years. If someone is instructor from other guidelines, from on which those are the ILCOR members, so they can definitely become a IRCF instructor as a lateral entry. Provider course will not be required, but they have to have the active instructor certificate for the different guidelines. And definitely we will have the online session and half day train the trainer program, where it will be structured training followed by an exam, MCQ, and definitely a practical assessment or change a difference from the other guidelines will be discussed. And these cards will be valid for 2 years. So this new platform has been developed by IRCF. Very shortly it will be launched, and this platform will have the comprehensive automated system, where even the provider, if you have done a provider course, you will have your own page that will tell you that when your card will be needs renewal. You will be given the updates, regular videos. You can always see the videos of the basic skills. So it will keep updating you.
You're not
We keep
audible.
update them for various. Uh, am I audible now?
Yes, now,
Am I audible now?
Okay. Yeah, you're audible.
Yeah. So IRCF is determined that we are connected with every participant who is a provider, not only the instructor, but the providers, so that we can keep updating them. We update their knowledge. They can revise the skills just by looking on their page. All the skills will be available. And that also, they become another new thing IRCF is starting, that they become the member of IRCF. Every provider, every instructor will be a member of IRCF. No extra charges will be taken for renewal of the certificates. Only a yearly membership and nominal charge will be taken on the yearly basis. So similarly, as a provider, I said instructor will have its own dashboard, and on instructor dashboard, the instructor will have its own instructor manual, instructor teaching materials, that what is the focus point when they are going for any course. So a quick review for every course, before every course they can do, they can read, they can be updated, they can connect it with the other instructor to discuss. So this is a comprehensive platform now we are coming up, so that all the resuscitation trainers, all the providers remains connected. And there will be, you need not to worry, an automatic update will come for when you need a re-registration. So this is how your page will look like. You can see on the right upper part that whatever, anything you want to do through this page, you can do it. You can create a course, you can apply to IRCF, everything. And so that you don't waste time for entering the data in the Excel sheet, nothing will be done. It will all be automated. And there will be a digital membership card for everyone, and your credential will be shown on your web page. So, and it will remain a dashboard for complete till the time you are instructor with IRCF. It will remain, all your certificates will be there. And a new thing which is the IRCF is coming up, it's not only the courses, Some courses will be mandatory, like 2 courses per year, at least 4 courses in 2 years before the renewal. But you need a 50 credit hours. So either you can do a 5 courses, or you can add by repeatedly taking exams which will be available on the online module, so that you update your knowledge, and few credit hours will be granted with that. Similarly, if you are doing any publication related with the resuscitation, that will have certain credit hours. So related resuscitation science related any activity you're performing calls, some credit hours will be given to that. So similarly, you can, in 2 hours you can earn more and more credit hours, and that gives that you are focused on the resuscitation. So the MCQs for instructors will also be a random MCQs, so that they can self-pace 24/7. They can see their progress. They can repeat if they feel they can repeat these questions, so that they can update their knowledge. There will be automatic renewal alert straight to your inbox, to your emails, to your WhatsApp, and you will get a SMS alert as well, so that you don't miss your, either it's a provider or it's an instructor, you don't miss your renewal. And we are making it very simplified, that you do every theoretical thing online, and you can just report to your CRTC, to your CRTC coordinator, or any instructor can look at your skill, and your membership will be, your certification will be renewed for another 2 years without any extra charges. So similarly for the instructors, they will be doing the courses, and they will be assessed by the senior instructors or the CRTC coordinator, and they will be given the points on that. So this is how we are going to renew our card in a most simplified manner. So this will be a fully automated, starting from online registration. If you will go on the website, it will first time it will ask you to register, and it will remain an OTP based logins, so that you don't even remember to the password, because we usually have thousands of password and we tend to forget these. Once you log in, depending upon the role, if you're a provider, your page will open. If you're an instructor, your page will be open. If you are a CRTC coordinator, your page will be different. If you are a state coordinator, your page will be different. So everybody will have the role-based access, so that all details are available. But everybody will have a teaching material depending upon their status. If they are a provider, they will have a teaching material according to the provider. If you are an instructor, you will have a teaching material according to the instructor. If you are a national coordinators, you will have access to all the data, so that you know that how many courses. And if you go to the dashboard, it tells that how many centers we have, how much we have trained. So this is all an automated um, system where we can do everything. And the charges, definitely it is going to have very nominal charges. Renewal will be actually free. It will be only a membership charges, so that you remain connected with the IRCF throughout your career. And you are getting a e-learning module, you are getting a resource libraries, you are getting a digital ID cards. And even for the different events like a CMER conference organized by the IRCF, you will definitely get a discounted rate. So I'll request all of you, those who have not done the provided course, please do provided course. We are coming up with the new guidelines, new books, new manual, and new platform. And become an instructor, because we as an anesthesiologist are the leader for teaching and training the resuscitation skill, and definitely lead in your hospital. Thank you very much. I'll be happy to answer any question related with this, because this is something very important, that we understand that how this is going to work.
Hello, thank you very much, sir. Excellent brief over the IRCF project. Now I request Dr. Shilpati Vaskar, madam, to go for question and answers.
Yeah, so you have answered most of the questions by all the faculties. The important question, like what you said, Dr. Vivek sir, I'll come to Vivek sir first. Suppose tomorrow at Baramati, I have to establish a center, CRTC center. So how do I go about it?
That's a very good and valid question, because this is the first thing should come
Like
in our
basic
mind.
writing email, calling whom should I call, whom should I write to?
An instructor of the IRC. It has to be written to the national body.
I have texted in the comment box. You have to write to nhq@cpr.india and copy to the director at the rate CBR. It is there in the chart box.
Yeah, you have written it. Yeah.
And a copy to the admin at the rate CBR.India. Definitely will answer. We'll send the necessary forms to sign an MOU and everything.
Okay, and for suppose we have only 12 people, then how much instructor, once you send the form, what is the procedure? How much days is required? Like, suppose I have 12 people, you send us the forms. So
actually, if we have 40 members, it is very easy for us to come and conduct a course and see the equipment also. Equipment is no shortcut for equipment. You should have everything. And 12 members means if you are in a medical college, it is very easy to have 40 members because every batch has to be certified Bcls and Acls. So they will not do. If you are
so now, sir, talking about the medical college, that was my last question. That why still the DNB board keeps on asking about AHA certified
No.
BLS
I can show you the letter from the DNB. You people have not followed. They have already certified the Bcls and Acls.
It will be so nice to share, sir, because I myself a DNB teacher and they ask us to renew our AHA.
Not only
program.
DNB, even ISCCM courses are there. Even for that, our courses are certified by them.
So any city branch of SAMS, if they want to make the center at their place, they have to write to you and then you will accordingly guide.
Yes, sure.
Okay, sir.
I think with regard to what Dr. Ma'am is asking regarding the national board and NMC, if they ask you that show on the platform or any checklist, because they use checklist during the inspection.
Yes.
So just ask them if you can, they can give you a document where it is mentioned AHA accredited course also. There is no document with them. So you can just ask them softly that do they have some checklist document which says only AHA? They will not have, and then you can very gently say that it is not mentioned as AHA, it can be any course. Then they will agree to it because some of the assessors has been trained long back and they were not aware of the other courses.
Yeah, they are
All
not
the courses
aware
are acceptable.
because at Maharashtra University it is written there AHA because they are not aware.
Yes.
No, actually there were only AHA certified courses till last 2017. Once we were accepted by LCOR, and now it is not. It is our LCOR means our first course is also certified. So even NMC has recognized BCLS. Only there was a rider for ACLS because the terminology was different. Now our terminology now is this time we have changed it to ACLS, and that is now accepted. So if NMC is accepting, NB is obviously is going to accept it.
University has to accept.
So we have.
There is a clear letter from NMC. I can send you. There is a clear
letter. Yeah. So I'll write an email to you, sir.
DNB,
So you can share.
I can send you. And regarding the AHA, there is no mention is made about AHA anywhere. And
In NUS's guidelines,
actually, see, my point is, I think we are over understanding thing. My point is the NMC, they said ACLS or NB said ACLS. Now this ACLS does not mean it is AHA.
Yeah.
ACLS is not a copyright of AHA. So ACLS is an everyone's term. We are also an ACLS, IRCF has also accepted ACLS. So that ACLS is again a component of IRCF as well. We had been using CCLS.
And now we have changed from CCLS to ACLS.
We have now, the recent manual which are coming up, we have changed because it's not a copyright of AHA. So we can also use ACLS.
The BCLS manual will be in my hands by the end of this month, and ACLS manual by 15th. Probably it will be released by the chairman of NMC by 15th or 16th.
Yeah, sir. And one more question was from our GC on my WhatsApp that why we since you are anesthesiologist, instead of renewing every 2 years, can we renew every 5 years?
That's what I told. there is no curriculum in anesthesia. Are they teaching CPR?
Yes,
No,
sir.
Is it
I
there
mean,
in the
suppose I'm
curriculum?
an instructor. Suppose, sir, I'm an
Maybe
instructor.
you are
No,
an
no, sir,
instructor.
he's not.
So why
See,
renew my instructor card every 2 years? Why not 5 years for an anesthesiologist?
See, for anybody, there will be a learning curve. So that you have to observe. And these are the skills. For skills, definitely you have to renew every 2 years. See, MBBS, you have studied, I studied about 40 years back. And my learning ground, because I am attending this many of credit hours per year and all those things, it is going on like that. So it is also the same.
So, and
No.
the second question to it was like, if
Silpa
our
madam,
guide,
Silpa madam, one thing I would like to mention here as well. See,
Yeah.
getting an instructorship for 2 years is not enough. You have to perform an instructor course every year, at least twice, because instructorship certification which you have, that's valid for 2 years. But obviously, but there's a rider that you have to perform the instructor courses, deliver instructor courses at least twice a year minimum. So if you're not doing it, then also you probably will not be able to valid. I mean,
Understood.
yeah, you'll not be able to justify yourself.
As anesthetic, madam, how many cardiac arrests you are developing and treating them in a year? You are claiming that
in OT, maybe occasional once a year.
so is it adequate to get trained?
Yeah.
That will be in somebody's hands.
Yeah, no, the second part of the question was, if our guidelines are changing every 5 years,
Yes.
why we need to renew every 2 years?
Yeah.
That I am telling it is a skill.
Yeah, okay. So renewing our skill.
The skill
Fine.
this skill is going to perish. You know, it is not that skill is always going to be. Of course, you can say that you're an anesthesiologist and you're doing it day in, day out. But CPR, you're not doing day in, day out. You are maintaining an airway, that is 100%. What about our chest compression? What about the DC shock? What about the sequence of events? You're not being able to train yourself with the sequence of events, which is most importantly, the outcome depends on that. So it is only one component of CPR. You know that you are an expert, that is the airway management. But others, you are not expert. You're not doing it day in, day out. So got to train yourself. That
Yeah,
skill is going to perish.
Got it, sir. Yeah. So I wanted to ask Dr. Rakesh Garg, sir. Sir, you have said that there should be de-emphasis on early intubation. Now, we as anesthesiologists start with compression, we check the rhythm, we start with shock and epinephrine. But once we had a real scenario around 8 months back in Mumbai, where a physician collapsed in his OPD and he was taken to a nearby nursing home. And the first CPR was started. The first thing, the intensivist or the whatever doctors were there, resident doctors, they are trained. So first thing he did was he intubated the physician and CPR was simultaneously started. And then of course the shock and epinephrine. So in one of your change of guidelines, you have said for epinephrine that do not ask what timing, just give it when you want it. So can we also keep intubation free of timing? Why de-escalate it? Why de-emphasize it?
So it is just de-emphasized because people have been struggling for securing the airway, taking extended duration of time. So now when we talk about airway management, the tools are many. So there are three basic category of tools. One is bag and mask ventilation. Second is supraglottic carrier device. And third is tracheal intubation. As we understand, tracheal intubation is a skill which many people will take some time. And that's why when you are asking about why 2 years of this, there is an evidence behind that also, that the skill decays by almost 1/3 every 3 to 6 months. So by 2 years, the skill, if somebody is not doing regularly, it's almost less than 10%. So this is a worldwide evidence coming from many places. So that's why there are two things here. One, we are emphasizing a continuous learning. because even 2 years sometimes may not be sufficient for those persons who are not doing regularly. So the intubation will take a longer time. So we don't want to waste time because cardiac compression is a priority and we can supplement euxin.
Agree, compression is a priority, but in new guidelines, why de-emphasize it?
De-emphasizing for the timing. So if you are comfortable using bag and mask ventilation to ventilate, go ahead and do it. If you are comfortable intubating in less than 10 seconds, go ahead and do it. But if you are struggling, because ongoing CPR cannot be done while airway management is being done. So if you are taking more than 20 to 30 seconds, for those reasons, we are de-emphasizing. As I mentioned, if you're an expert, you can do it. But when we say start CPR, the CPR is being done outside the hospital premises and outside the intensive care and anesthesiologist domain. The most of the 80 to 90% of the cardiac arrest is happening outside the domain of anesthesiologist. So the worst person who is taking care of is not an anesthesiologist. So that's why when we make guidelines, it is for majority. So majority are non-anesthesiologists. That's why we say go ahead and do the ambu bag ventilation. But if you are inside the critical care unit, if you are the emergency physician, if you are the anesthesiologist, if the equipments are ready for you, go ahead and do it. Sometimes even getting equipments is a big issue because you will bring the laryngoscope, you will bring the intubation set, you will bring the tubes, it will take some time. So meanwhile, we say continue bag and mask ventilation. That's the purpose of de-emphasis. So it should not be that only intubation should be done.
See, actually, understood. My point is now one very important thing which we are missing here is that whether your bag mask ventilation is adequate. So if you're comfortable means you're adequate. It's adequate. That means your chest rise is there. Patient is not being, you're not insufflating the stomach. If it is adequate, you can 100% go ahead with your chest compression. There's no issue about intubation at all. Unless you're not adequate, you're not being able to ventilate, you can think that yes, you need to, then you can put a supraglottic airway device. That also not an intubation. You can put a supraglottic airway device. So that's the bridge between intubation and bag mask. If you're comfortable with supraglottic, then you can think of intubation, because intubation definitely is going to take more time than supraglottic. And any technique which is going to take more than 10 seconds is not acceptable.
Understood, sir. Sir, can we request that can we have some videos also in presentation of IRCF? And can we emphasize, for example, we have to do a 4-hour course for Bcls, but sometimes teaching and everyone practicing gets over in 2 hours. So can we say something like that, I'm not comparing with AHA, but something like that, do it at least 5 times in our course in Bcls. That one person does compression, do it again 5 times, it's total 5 times. So I hope I am able to convey what I mean, some compulsory times that person has to repeat the thing. Or can we have some videos during our IRCF training where we can show the videos also how they are doing, or what was the mistake, what is the correction, the audio visual might, also improve it, or what do you feel, sir?
So if you
We
see
had
the
an animated.
If you see the recent schedule that is being shared by Dr. Rashesh Dewan when you organize a program, it has 3 components. One, the topic. Second is the objectives. So that schedule we have drafted again. So it is mentioned very clearly that each candidate will do it 5 times. So which you ma'am rightly mentioned. So that change schedule is incorporated the learning objectives for the participants to do it mandatory during the program. So whoso have done it recently in last 2, 3, 4 years, that rescheduled with objectives are already there. But yes, your idea is well taken to include videos. But when we have conducted a lot of feedback from the people, people are not happy to see the videos. So that's why when we take training of trainers program, so TOT programs, we emphasize them to demonstrate. So demonstration can be done at 2 points. One, while you're taking lectures. So for video, it will be better because when we take a video, it will be say 1 angle or 2 angles. For example, if you want to teach bag and mask ventilation. So as a trainer, during the training of trainers, we'll say that you keep one mannequin and a bag mask in the area itself. And that's why sitting arrangement should be a C tape so that everybody can see and demonstrate while you're teaching it. So this is one option. Second, when you go to the station, the first step is demonstration and then the candidates too. So we are re-emphasizing the things again. But yes, your point is well taken for the video. So we'll try to incorporate in the recent coming times.
So we had,
Okay, sir.
we had incorporated videos which was in animated format, but that did not come out that nicely. People did not, like those anime. If you remember, Rakesh, we had an animated videos, and we still have it. In fact, in some places we show it, especially in certain areas. So that animated videos can be used, but it again you have to see whether the acceptability of that animated videos are well, because it depends upon the audience.
Yeah, medicals, non-medicals. Sir, and we have been saying,
many people are watching the mobile.
and every time we are saying that ILCOR and IRCF is getting feedback and revising guidelines. Means what exactly, like suppose I'm working in a hospital, I have three ICUs attached, but IRCF or ILCOR taking feedback from the hospitals? Yeah, how many you had arrest? How many were survived? What technique was used? Like when we talk about, I'm sorry, I'm just curious to ask. Like when we talk about, we are getting feedback every year and we are reevaluating ourselves. So what exactly was the process or thought process in this?
So the thought process is ILCOR is an organization which has 8 task forces in different areas, and these task forces round the year, even now one meeting is going on. So round the year they will sit together. So they will have 15 to 20 peoples. Some of them are actually very good in systematic review meta-analysis. So for example, if Dr. Shilpa Tiwaskar did a good study and reported 500 patients of CPR, so they will capture it. So within say 1 to 2 weeks, we will know that this new study has come up. And then it will see that if the new studies corresponds to the original evidence, they will continue. If something is very different, we will do a systematic review and meta-analysis that whether things needs to be changed. For example, very recently, the airway management, the use of calcium, the use of temperature management. So these circulars, these discussions go around the year. So usually all the task forces will meet on Zoom meeting every alternate week for almost 1.5 hours. And they will do a systematic review of all the new topics. And then in 1 year, the all task forces meet at one place. For example, this time they are for the first time meeting in India. So all the 225 members will be sitting in the rooms for 3 days and will review all the science and they will release it. So that's why if you saw the ILCOR, there will be something called evidence generation.
So it's a global data.
This is a robust data, madam, but this is a global data. So the problem in the global data happens is that all the global data may not be applicable to Indian population. For example, say in 2019 or 2018, there was something called targeted temperature management. For targeted temperature management, we required a device which controls the temperature. And this device was not at many places in India, though it has been released last year by some company, but before it was only at 2-3 centers. So we didn't have a targeted temperature management. So though it was well applicable in US because each hospital has, but in India it was not having 6-7 years back. Now, last year this equipment has been released, but now the evidence has changed a little bit that we have to look for more of hyperthermia, fever control, rather than managing the strict hypothermia, because keeping the patient on 33, 34 degrees Celsius will lead to a lot of coagulopathy, renal dysfunction, and other aspects. So this new evidence has come up. So don't worry about those evidences. Evidences is more for the academician. But if you see,
No, so I was not worried, sir, sorry. So I was wondering whether, like how we take data, how our government takes of infectious diseases. So can every hospital be asked to give data to IRCF?
I'll be very happy, madam. Shilpa, madam, if you can take this initiative and become our lead member, we'll be more than happy to coordinate all the activities.
We are
across
starting a ministry of cardiac arrest. We are starting, almost it is done, and that man is not found. So probably within 1 or 2 months, the registry will be open for everybody, and whatever incidences you report, and then we can take out the data and everything from that.
And sir, just now I'm talking about the temperature. So what is the temperature you expect to keep, expect us to keep?
So 2 things, ma'am. One, if somebody is febrile, treat them with cold sponging, not covering them, keeping them on ambient temperature, not putting on blanket or bear hugger. not giving them free fluid. So control and give paracetamol. So this is what preventing fever. If you keep a patient just with a plain sheet, the temperature will be around 35, 36. That is acceptable. Any temperature below 30, 33 is not acceptable because it will lead to more of injuries. So active rewarming should be avoided as per ICF guidelines and prevent hyperthermia. If yes, treat them.
So last question from my side, Avinash sir. You said do not give 100% oxygen. So, but our tendency is post ROSC. So our tendency is pehle 100% oxygen. So is it that we should give initially 5 minutes, 10 minutes, and then start reducing it?
So if there is an uncertainty, because initial perfusion is not happening, give 100% oxygen high flows. Once there is return of spontaneous circulation, monitor this patient using pulse oximetry and ABG wherever required. At this junction, try to wean off the oxygen. So the weaning will start. So wherever,
after how much time of ROSC
so
you recommend?
It should be say once a patient is stabilized. So if you see the whole guidelines, we are never putting the time frame, because time frame will be different. For example, the arrest has happened in the ward. The patient is being shifted to ICU. In some places, at my place, it will take half an hour. In some place, it will take 4 an hour. In some place, it will
after ROSC, after return
after ROSC, after into a monitored area, patient has been stabilized, monitors has been applied, the reversible causes has been taken care of. Try weaning them off from these agents, including oxygen.
There is one question from Dr. Sachin Chandolkar. Can TOT programs training can be taken in national conferences?
Yeah, we're doing it.
It is being done, madam. I think at many centers, even in Maharashtra state, we have come many times for TOT. So Dr. Vivek has already
in national
mentioned.
Conferences.
National conferences, people are
TOT you have done with us only, Nagpur.
I know, madam. So, I mean, in national conferences, yes, we can do it because we do the BCLS and CCLS, that is now ACLS courses, that is of 2 days. So people have to come on Monday. So the whole week will be there. So I think that's why getting 1 week leave for many people is a big issue. That's why we try to avoid TOT. But yes, if you want, we can do it, madam. Should not be an issue, madam.
So it will require 2 days now.
Maybe next year we'll think of something, madam. Don't worry.
Okay.
Yeah, over to you, Sheetal madam and Avinash sir.
Can I comment a little bit?
Yes.
I'm Dr. Sanjay Kriplani.
He's a MMC observer today.
I'm director of critical care at Max Hospital, and our institute is JCI recognized. 4 years back, it was compulsory from the JCI to have the targeted temperature management in our code blue sheet, and we used to do for all the patients, and it was mostly surface cooling, and we could achieve the targeted temperature of 34 to 35 in almost all the patients. And later on, as the guidelines changed or as the studies changed, we stopped, as the sir rightly said, to control the hyperthermia and to maintain the normothermia. So you don't require high-end gadgets for targeted temperature management. We have done it extensively for 2 years, and now we have stopped using targeted temperature management. It was a surface cooling, IV cold salines and surface cooling. We have a blanket which can control the temp through an external device. We can control the temperature, and that we were using extensively post ROSC to almost all the patients. But the second issue, the other issue with targeted temperature management, which we faced initially after ROSC was that once the patient is had a cardiac arrest, and for 24 hours you are keeping him paralyzed and sedated, and neurological recovery is not known. Many times the next thing which the problem or the issue is to convince the patient's relative that your patient will be comatose for next 24 hours and we will be able to assess you only after 24 hours. So that is one of the additional counseling that we need to do with the patient's relative. And broadly, targeted temperature management broadly did not give us any major issues for the 24 hours in most of the patients, except little bit electrolyte, this thing. Rest of the things were absolutely normal, but we have stopped using it. we used it for 2 years. That's it from my side. Thank you.
Absolutely, but I must acknowledge that your center is a good center and it has a good monitoring. So you will be using the core body temperature or the skin temperature that's required, and you will
Yes.
be using urine
Yes.
output. You will be using the cardiac output
Yes.
parameters.
Yes,
So it is
absolutely.
already the equipment, the paraphernalia for TTM was including everything. Coagulopathy happens, so you will be sending them for coagulopathy status. Renal dysfunction can happen, so
Absolutely.
so these things were already there. But you rightly said that it's doable. Now we have in India those TTM equipments are available. So if somebody even there is some indication just for the evidence base, not for guideline. Even today, there is some indication for TTM. If somebody has prolonged CPR with probably neurological insult, they become the selected population for TTM. So there's not totally out, because when we say guidelines, it is for majority. So for example, if you have taken say 45 minutes, 60 minutes of CPR, it was a good quality CPR, but post CPR, the patient was not having some neurological insult, neurological outcome was not good. Then you initiate TTM for 24 hours, as you rightly said, sir, and then re-examine them. So we are preventing that whatever hypoxic injury. So there are some indications, but as a global change, the more emphasis, more harm was being caused by febrile episodes, which was reactionary febrile episodes in many cases. So that is absolutely so very important input coming from Kriplani sir. Thank you, sir.
Thank you very much, sir.
Thank you
It
very
was a
much.
great insight, sir.
Thank you, sir.
Thank you very much.
Sir,
Since
I have
Shilpa
one
ma'am,
question. Sir, I have one
sir,
question. Can I ask?
madam,
Hello.
no, hello.
Sir. Sir.
I know there will be many questions. Since we have exceeded the scheduled time, I would request we conclude the session here, because it's 9:20:25 already.
Only one clarity, sir.
Sir, thank you very much for all of you. My sincere gratitude towards all the speakers for accepting our invitation. We are waiting this webinar since long time. And I really thanks to the CPR Man of India, Dr. Chakrarao sir, Dr. Rakesh Garg sir, Dr. Rashid Diwan sir, Dr. Syed Mohit sir, and Dr. Vivek Gupta sir for accepting our invitation and sharing all the insights or the evidence-based medicine regarding CPR, ways for effective CPR, then what are the recent advances in doing CPR, what are the process of IRCF and how it works. And especially thanks to Dr. Vivek Gupta sir for giving me the scheduled scientific program. And thank you very much. And I also like to thank Dr. Sanjay Kuprani sir for MMC Observer. And thank you to all office bearers, GCs or delegates for supporting me today and always. Many more attendance today is there and so many discussion over this important topic of saving time. So take the pledge that everybody should be a lifesaver. So thank you very much. Long live ISA, long live SAMS. Jai Hind, Jai Maharashtra.
Thank you.
Thank you.